So I want to welcome you all to an MS Views and News educational program. This is a Compass to MS Care event. We do these programs around the country. We are the #1 MS organization in the United States providing programs in rural and underserved communities, again, across the U.S. So, this is a reason why we're here today and why we want to break out and do more programs in the state of Mississippi. We used to get all over the place in Alabama. Now everybody there knows where to get their information from, so that's a great thing, and you all will one day too. All right, so for tonight, I just want to let you all know that Dr. Mary Willis is speaking for the entire program. I want to thank our sponsors. We have, and I hope you all do too, all right? We have Bristol Myers Squibb, we have Genentech, Sandoz, and TG Therapeutics. Those are the companies that supported tonight's program, and we should give them a round of applause, don't you think? Thank you. Thank you. Our exhibitors tonight, which you saw outside, we had Alexion, Biogen, Bristol Myers Squibb, EMD Serono, Novartis, Sandoz, TG Therapeutics, and Viatris. They're all here for a reason, everybody. They want to make sure that you all are getting the resources that are available for you to learn more about your MS or for your caregiver or whoever it is that needs to just learn more. So again, tonight's program is going to be, so the doctor is going to speak for about 45 minutes, yes? And then we're going to do Q&A. So thank you very much, and I'll speak with you all later.
All right. Thank you, Stu. And we're going to find out if I can follow instructions and talk while using both hands at the same time. So this is new. We're going to cover a lot of ground tonight, and hopefully this is going to be useful information. Some of it you'll know already, but I wanted to make sure that going into the Q&A, we're all on the same page. So it'll be kind of an MS 101. And so for my disclosures, I do speak for Biogen, Alexion. I serve as a consultant for Bristol Myers Squibb, and I'm on the board of trustees for the local chapter of the National MS Society. Tonight's talk is sponsored by MS Views and News, and I'm so appreciative to have this opportunity. I've been back in Mississippi since 2019, and I was sharing with Stu that in this area, we don't have many of these programs to attend, so I'm happy that we're getting started with some education. Now, about half of you in the room have shared your MS story with me, so I thought it would only be fair if I started off with my MS story. I don't have multiple sclerosis, but it's a very important part of my life. I didn't even know anyone who had MS until I was in medical school, until my third year of medical school. That's when I met the first person with multiple sclerosis. And some of you may know what happens in medical school and how we get into residency. We have to get letters of recommendation. So, we try to make ourselves look good when we go to clinic. And I happen to be in clinic with a neurologist who is a sort of a grandfather of multiple sclerosis. He was the one who found myelin basic protein in the CSF of people with MS long before we had any treatments. So he helped understand, what is MS. And I was going to clinic with Dr. Herndon. The day before, I looked at his schedule, and all 20 people on his schedule had the same diagnosis next to their name. The next day, I went to clinic, all 20 people looked incredibly different. And you've heard that no two people with MS look alike, and that's absolutely true. And that's what first drew me to multiple sclerosis and learning more about it. I am the kind of person I don't like to be stumped. And so that experience taught me I have a lot more to learn about this condition. So since then, my MS journey began when I was a fellow at Cleveland Clinic doing my MS fellowship. And since then, it's been, I hate to tell you how old I am, but we're going on almost 15 years as an MS specialist, and I've taken care of about 5,000 people with multiple sclerosis. So I know lots of people, have lots of friends with MS now, and this is something I live every day, even though not in the same way that some of you do. This has become a family affair. You see my kids here. My kids both of them are 5-year veterans of the MS walk. When they're old enough, maybe I can get them to do the bike MS events. And you can see that I try to get everybody in my team involved in supporting MS and MS awareness. So this is the UMC Neurology MS team from a couple of years ago. So we're working hard to try to get the word out and awareness about this condition. So tonight, like I said, this will be sort of an MS 101 to get us all on the same page before the question and answer session. We're going to talk about what is MS, symptoms, who gets it, why, how do we diagnose it. We're also going to talk about what can we do about it. What are some of the treatment options? How do we decide on the treatment options? What should we expect them to do? We won't touch very much on what's coming down the pipeline, although we can certainly talk about that in the question and answer session. And we'll talk just a little bit about symptom management. Stu gave me a very broad topic, so we're going to do the best we can to cover all of that. So what is multiple sclerosis? And there are a few key things you need to know about it. It's inflammatory, it's demyelinating, it's immune-mediated, and it involves the central nervous system. So knowing that it involves the central nervous system and understanding what that is really important. So, multiple sclerosis doesn't involve the joints, it doesn't involve the skin, but it does involve the nerves that go to the back of the eyes, called the optic nerves. It involves the brain and the spinal cord. It's an immune-mediated condition, so there's something wrong with the immune system that causes attacks on the myelin. And I've explained to many people that a nerve is kind of like the cord that you plug into the wall. There's a wire in the center, and then there's insulation on the outside. A nerve is very similar. So there's an axon that goes down the middle, and the stuff that covers it, the stuff like insulation, is called myelin. So when the immune system attacks that myelin and strips it away, just like stripping insulation off a wire, you get short circuits. So you get a lot of symptoms that some people may think are weird or strange. But that happens when that myelin is attacked, and sometimes the underlying nerves can be damaged in that process. The name multiple sclerosis literally means multiple scars. So when we look at MRIs, and I'll show you examples of this as we go along, those white spots that you'll see, those represent areas of scarring. And that's how MS gets its name. So what's really happening in MS? And this is what you'll be tested on later. So I'll ask you some questions at the end, and it'll be about this slide. Not really. But this is what's happening in the immune system, just a cartoon depiction of what we think is going haywire in the immune system of people who have MS. And you can see that there are lots of different things going on. And, in some ways this is good because we have lots of different treatment approaches that may work to help in MS. In another sense, it helps you understand why everyone with MS looks a little bit different. So what's going on in the immune system with one person who has MS may not be exactly the same as it is in another person. Because of everything going wrong with the immune system, you can have lots of different symptoms depending on what part of the nervous system is involved. So if that immune attack is on the optic nerve, you may get blurred vision, pain with eye movement, vision loss. If that immune attack is in the spinal cord, you may get weakness, trouble with bladder, trouble with bowel. So the symptoms depend on what part of the nervous system is involved. And so what are some of the common symptoms? And this is just a very short list, but it gives you an idea of what percentage of people with MS experience these symptoms at any point in their MS journey. And I think, many of you would probably agree that these percentages are underestimated. Optic nerve inflammation is very common, so we call this optic neuritis. Poor balance, dizziness, weakness, double vision, bladder and bowel problems, pain. What you don't see on this list are things that are even more common but less visible. So that's one of the things about MS, is that there are a lot of symptoms that people can't see, and it makes them hard to understand. People can't see fatigue, but I've taken care of very few people with MS who don't have fatigue. It's extremely common. Heat intolerance, and this is something that if you were allowed to talk, every one of you would say, absolutely. It's been 107 degrees here for the last 2 weeks, so the heat intolerance is no joke, and something that many of you in this room have very much experienced over the past few weeks. Difficulty concentrating is a less visible symptom, but it's very real, and it makes it hard to interact with other people sometimes. It makes it hard to keep up with work. And it's also hard for people to understand because they can't see it. So we'll focus on some specific symptoms. One I wanted to point out was optic neuritis. We've talked about this a little bit. So optic neuritis is usually an event. It's not a symptom that comes and goes. When it comes on, it usually starts as blurred vision. It can be just kind of like a smudge in your vision that you may not pay attention to for a day or two. And then that vision gets worse over the next few days. Pain with eye movement is sometimes there, and colors just don't look right, particularly reds. They may kind of have a brown color, but it may be hard to see other colors as well. We don't always see anything abnormal when we look at the back of the eye. So I've showed you a picture here. This is what I see when I look in the back of someone's eye, or what I'm looking for. If I see this, I am pretty certain that someone has optic neuritis, but sometimes when you look at the back of someone's eye with optic neuritis, you don't see anything at all. And this can make it hard to diagnose if you see someone who, as you see an ophthalmologist or you see a neurologist who doesn't know anything about multiple sclerosis or optic neuritis. So you may be told, oh, well, your eyes look good. Abnormal sensations are also really common. These can be numb, tingly, sharp, electrical-like, crawling, burning, band-like, can feel like water on your skin. You name it, I've heard it in terms of abnormal sensations. Unlike optic neuritis, these very often come and go. So they're not the same throughout the day, and they may be different on a day-to-day basis. This indicates usually past damage that was done. So we can see some of these symptoms develop with the relapse, but most of the time, the coming and going of these weird sensations indicates old damage that has been done. Like I said, fatigue is extremely common. It's so common that I've only met a few people with MS who don't have it. It's not specific to MS. We see fatigue with lots of other things, but it's often worse in people who have MS. So what do we do about it? Because it can be disabling. We start by looking for other medical causes. So thyroid disease, anemia, vitamin deficiency can all increase fatigue or cause fatigue. Sleep problems, and sleep problems are extremely common in people who have multiple sclerosis. Sleep apnea, restless leg syndrome. If you're not sleeping at night, of course you're going to be fatigued the next morning. Believe it or not, decreased activity increases fatigue. So some physical activity is one of our strategies for fighting fatigue. Sometimes worsening fatigue is associated with difficulties with mood. When people are depressed or they're anxious, it's common for them to describe fatigue. And of course, we can have neurological fatigue that comes from other places. Heat intolerance, like I said, is no joke. Those of you who are online from Mississippi or the southern states will understand that heat intolerance can worsen old symptoms. So if you've, for example, had an optic neuritis in the past and you walk outside to your car and it's 105 degrees, your vision may be blurrier than normal, but then when you go inside and you cool off, it gets back to the way that it was before. It's not just outside temperatures that are associated with heat intolerance. Sometimes people experience this with hot showers. It happens with fever or infection, happens with exercise, and it usually improves with cooling or treating whatever is going on. So who gets MS? It can be anybody. At the time that I was in medical school, most students were taught that this was a disease that affected white women in their 20s and 40s. And that's true that white women in their 20s and 40s do get multiple sclerosis, but I've seen children with MS, and I've seen people who have new diagnoses of MS into their 70s. So age is nothing but a number. It can happen outside of that age range, but it is more common between ages 15 and 50. It doesn't have to be a woman who has multiple sclerosis. Men get MS. And it doesn't matter whether you're Caucasian or African American, anyone can get multiple sclerosis. It's also not a rare disorder. There are 1 million people in the United States living with MS. So this is more common, I think, actually than that. I think the last numbers that came out of the CDC and the National MS Society are probably underestimates. But about 1 in every 1,000 people has multiple sclerosis. And you see some pictures here just to give you an idea of how MS can affect anyone. It can be someone who is completely healthy and very active. There's not anything that you do to bring on the MS. We do see somewhat of a geographic distribution. This is old data, but in general, the farther north and south you go from the equator, the more common multiple sclerosis is. So MS, to me, seems to be very common in Mississippi, but when I practiced in Cleveland, Ohio, there was no one who lived there who didn't know someone who was affected by MS because it was so common in that area. So why? Why do people get MS? What causes it? And the short answer is we don't know all the factors. We know some of the things that lead to risk for MS, and there is somewhat of a genetic predisposition, but this is not a hereditary disorder. So there are some genes, when they're present, they increase the risk that someone will develop MS under the right circumstances. Vitamin D deficiency does seem to be associated with risk for developing MS. Cigarette smoking and some other environmental exposures increase the risk of developing MS, but we don't know all of those environmental exposures that contribute to risk. The closest association that we know of with risk for developing MS is exposure to the Epstein-Barr virus, particularly during childhood. People who have Epstein-Barr virus that causes mononucleosis during childhood are much higher to develop MS as adults. What we don't have any evidence for, we don't have any evidence for heavy metal exposure, aspartame exposure, not that many people are using aspartame nowadays. We don't have any evidence that trauma causes multiple sclerosis to develop. So there's not clear evidence that things that you do actually lead to the development of MS. It's a myth that MS is hard to diagnose. It's really easy to diagnose. We have diagnostic criteria, which I'll show you on the next slide, that make it pretty simple to diagnose MS if someone knows what to look for. And so the first thing starts off with just listening. Your neurologist or neurology nurse practitioner should listen to the story that you're telling them. Most of the time, we can know who likely has MS just by listening to the story. And then the neurologic exam may point us towards increased likelihood of MS. So this is step number one. Hearing the story, looking at the neurologic exam is the most helpful thing in figuring out when an MRI is needed. And then MRI of the brain is still the most sensitive test we have for diagnosing MS. Yes, there are other tools that we can use. We can do MRI of the spine. We can do a lumbar puncture, also called a spinal tap. There are electrical tests called evoked potentials that we sometimes do. And then there is a whole bunch of blood work that we do to rule out other things, like lupus or Sjogren's syndrome, or some of you may have heard of some other neuroimmune conditions like MOG or NMO. We can do blood tests to look for those things, and sometimes other imaging tests to look for things like sarcoidosis that give the same symptoms as MS, may give the same exam findings, but would need a different treatment. So I just put this slide up here to show you that there are a set of guidelines that we follow in developing MS, in diagnosing MS. These guidelines have been developed and refined over several decades. And so the last revision was in 2017. I think there will be a new revision coming out very soon. But this is a guide for doctors to be able to diagnose MS as quickly as possible. So using these criteria, it's very often possible to diagnose someone with MS with their very first attack. And that's the goal. You know, the sooner we diagnose MS and we start treatment, the better someone with MS does. As far as MS mimics, there are lots of them, and we're not going to go over this slide in detail. I just wanted to impress upon you that there are lots of things that can look like MS, that can look like MS, that your doctor has to take into consideration in making the right diagnosis. The main tool is MRI of the brain. We use this not just for diagnosis, but as you'll see as we go through the slides, we use this to help us understand if our treatments are working. So let's talk about those white spots on MRI. Not all white spots are the same. The white spots that we're looking for that would help suggest multiple sclerosis happen in very specific places within the brain and the spinal cord. So the four regions that are important, and I've put some examples here, are periventricular lesions. These are white spots that touch the surface of the ventricles here. And I'm sorry, you probably can't see the pointer from the very back of the room, but the white spots that are next to those black fluid spaces, those are called periventricular lesions. The yellow arrow there is showing you a juxtacortical lesion. And then we can have lesions in the brainstem, so in the bottom part of the brain, or in the spinal cord. And all you need are lesions or spots in two of those four areas for us to check off one of the criteria for diagnosing MS. So that's what we're looking for. Sometimes the white spots on MRI are not MS related, but sometimes they are, and we're looking for that specific pattern. And here are some examples of what MS looks like on MRI. From a side view, those white spots that touch the ventricles, they may stick up like fingers, and we call those Dawson's fingers. I've shown you here also a spinal cord. It's a side view of an MRI of the neck. And the gray color that you see there in the center that's surrounded by that white stuff is spinal fluid, and that gray thing is the spinal cord. Gray is the normal color of the spinal cord. When we see white spots, particularly short white spots within the spinal cord, that makes us think about multiple sclerosis as opposed to other diagnoses. So here are some other examples of white spots on the MRI, and below that I have paired with that images after contrast. So those of you who are in the room who have multiple sclerosis, you know what I'm talking about. You go into that MRI machine, they take pictures for about 20 minutes, they pull you out, they give you dye in the IV, they put you back in, and they take some more pictures. And the reason we do that is the contrast helps us know which spots are new and active versus which areas are scars, like I was talking about. So all of the white spots that you see there at the top on that top row, those are all areas of scarring. And some of them are old, but some of them are new. So the bottom row shows you spots that enhance with contrast or light up with a dye. All of those are new and active MS lesions. But because you see some that don't light up with a dye that are there on the top and some that do, that tells us that this person has multiple sclerosis. It's something we call dissemination in time. It also tells us that the MS is active at the time of the scan, and we need to do something with medication to shut down the activity or the inflammation. So one of the questions that I get very frequently is, well, what type of MS do I have? What types are there? And this is an old slide with some old categorizations. I personally don't like the term benign multiple sclerosis. As someone who has known now many people with MS, I don't think it's ever benign. Although there are people who don't have a lot of physical symptoms, may not have a lot of invisible symptoms, but it always impacts someone's life to even have a diagnosis of MS. So I would argue that benign MS doesn't truly exist. By far the most common type of MS is relapsing remitting MS. 85% of people have relapsing remitting MS at the time that they're diagnosed. So this looks a little bit different from the other forms in that people will have relapses. They'll have new symptoms come and stay for at least 24 hours. Usually it's a period of a few weeks before those things begin to get better. And then there will be a period of time where nothing new happens. You may still be dealing with old stuff, but nothing new happens for a period of time. And then there's another event, another relapse. So that's what relapsing remitting multiple sclerosis is. And many people who have relapsing remitting MS eventually go on to develop secondary progressive MS as a result of the old damage that was done and probably some smoldering inflammation that our medicines don't get to very well. Primary progressive MS is a less common form of multiple sclerosis. And this looks a little bit different from relapsing remitting in MS in that when I talk with people who have PPMS, they can't remember a time where things suddenly got worse. Their description of how their problem started is that it was very gradual. So they noticed over at least a year that symptoms, old stuff, was gradually getting worse. This type of MS is trickier to diagnose and really does take someone who has experience diagnosing and managing MS to be able to pick up on that diagnosis. So this slide shows you sort of the different phases of MS, if you will, and I realize now that I see the size of the room that this may be hard to see from the back. The arrows on the very bottom indicate MRI activity, and it's important to understand that there's a preclinical phase. There's a time before someone develops MS symptoms that stuff is still going on underneath the radar. So usually when someone is diagnosed with MS, I look and I see that they have old stuff. They have white spots and they never had any symptoms to go along with that. So this slide with the arrows in the preclinical phase is showing you that the stuff on the MRI can happen even before the first relapse. So the MS is already set off and has a head start on us before someone shows any symptoms. And then paired with that is brain atrophy or brain volume begins early on in the course of MS. And this is something that's a relatively new understanding for us in the MS world and something that we're paying attention to, and you'll hear more about as time goes on. Our clinical trials now almost all include some endpoint or some measure of brain volume, because it's not just enough to prevent relapses, but we want to save brain as much as possible. So what is a relapse, now that we're talking about that? A relapse is new or worsening neurological symptoms that stay for at least 24 hours. So I tell people, if you get a numb, tingly thing that goes away within a few minutes or few hours, don't sweat that. That's not an MS relapse. If your symptoms stick around for 24 hours, that's when you need to give me a call and let me know that something is going on. Sometimes those worsening symptoms that are there for at least 24 hours are not a true relapse. They may be something called a pseudo-relapse. It's associated with infection, stress, sometimes new medications, but that's still something that your care team needs to help you sort out. So if it's been there for 24 hours, it definitely deserves a call to whoever is taking care of you. So how we treat relapses is pretty simple. I mean, most of you have already experienced this or know someone who has. The treatment for a relapse is sort of like a fire extinguisher. I mean, it's not going to, necessarily impact the overall course of the MS, but the goal is to quickly put out inflammation. So we damage that myelin as little as possible, and the repair is easier for your body to make. So first, we treat infection. So if you've called in and your doctor said, well, I need you to go get a urinalysis first, it's because we want to make sure that there's not an infection driving the worsening, and something that we would make worse if we gave steroids. So if you have an infection and we give you steroids, it kind of fuels that infection to possibly spread to other places. Treating the symptoms is important. Sometimes it's not enough to just give high-dose steroids. For example, if a relapse is associated with really bad muscle spasms or severe nerve pain, we may talk about, in addition to doing steroids, doing muscle relaxants or doing medicines to help calm down those irritable nerve membranes. The steroids that we give for a relapse are usually very high dose. So 1,000 milligrams of Solumedrol daily for 3 to 5 days is my usual protocol, although there are other ways to give high-dose steroids. An oral prednisone taper may or may not be part of your treatment, but it is something that many neurologists will do after a course of high-dose steroids. Sometimes plasma exchange is used, so some of you have read about plasma exchange and IVIG and may have asked your team about that. We use that for people who don't respond to steroids or have, really, really severe symptoms from their relapse, and the course of steroids doesn't give them enough improvement. And this, I talked at the beginning about my MS bike team and MS walk team, and I'm always trying to recruit more people. This was actually my first MS bike. So I biked 75 miles with this team from the Mellon Center for MS. And these are my favorite jerseys that hopefully I can bring back to an MS bike team here for this chapter of the National MS Society. All right, so we've talked about the symptoms of MS. We've talked about who gets it. We've talked about the why, or what we know about the why. We've talked about the forms of MS. We've talked about the basics of identifying a relapse and how to treat it. But what do we do about the MS itself? Steroids are just a fire extinguisher, so how can we prevent those new scars from forming? How can we prevent relapses? And we have lots and lots of things that we can do about that now. So there's no cure yet. I do think that there will be one. And I'm happy to become a different type of neurologist when there's an MS cure. There are now more than 28 medications, depending on how you count, generics, approved for treating relapsing remitting multiple sclerosis. For other forms of MS, there are fewer approved treatments, but there is hope that we'll have more approved treatments very soon. Because there are many more medications in trials. There are interventions like Epstein-Barr virus vaccinations, stem cell studies that are going on. And we'll briefly touch on some of those things. But at the end of the day, our goal with all of our current therapies is to prevent relapses, prevent MRI changes, and ultimately prevent disability. So how do we know if the medication is working? We have to ask about and look for symptoms of relapses. We ask about changes in activity, in terms of looking for worsening on neurologic exams. Sometimes we get clues in the forms of your regular neuro exam or by doing standardized tests like a 25-foot walk, a 9-hole peg test, calculating something called an EDSS. Sometimes we get clues from that, but really what's most helpful to me, what has the most impact and helps me understand whether there's progression or not, is you telling me what's changing for you. So what has changed? What are you not able to do now that you could do at your last visit or that you could do a year ago? We also look at MRI of the brain. It's an important diagnostic tool, but it's also helpful for us to understand whether the treatment's working. And here's what I mean. So here are a pair of MRI brains. So all the way to the left, you see January of 2001. I know a very old school scan, but this is still what they look like. Those white spots are areas of scarring. None of them were active at the time of that January 2001 scan. This person had a repeat scan done in April of 2001. And the circle there is showing you a new or enlarged lesion. And that last image there is after contrast was given. You see that it enhances, so that's an active lesion. When we see that, we know that the treatment is not working, or that it's too early for it to have started working. As a reminder for your pop quiz later, this is what's happening in the immune system with someone with MS, or what we think. And that means that there are multiple targets for our new medications. This is an abbreviated timeline of what's happened in MS treatment. So when I started in MS, we had just the stuff that's there to the far left. We had shots. We had a chemotherapeutic medication called mitoxantrone that's not used very often for MS care anymore. And we had natalizumab. But all that stuff to the right of 2007 has developed for treatment of MS, and the last few years are cut off. If I had this extended all the way to 2023, you would see even more medications in development for treating multiple sclerosis. So there is no other field of medicine that has had this rapid development. So there's been a lot of research, a lot of work in understanding what happens with the immune system in MS and developing effective treatments. So here's a table of the treatment options. This is the second item on your pop quiz. We call these disease-modifying therapies, or DMTs for short. In the past, we referred to something called ABCR drugs, or platform drugs. ABCR is the first letter of each one of the first medications that we had that were all shot medicines. Now we have 24 or 28 options. There are many different mechanisms of action, and we're not going to go into details about all 28. They have different durations of effect. So some of them last for 6 months, and some of them last for 12 hours before you have to take the next dose. They all have different screening labs and lab monitoring. So how do we choose? I think the first step in understanding how we choose is understanding the treatment approach. So there are two different schools of thought. One school of thought is that you start with a weak MS medicine, and then you move up, you step up to a stronger MS medicine when someone has a relapse or when they have the change in the MRI. The other approach, and the one that I use and many MS specialists use, is something called early highly effective therapy. This means that you use a stronger medicine, one that's more highly effective, at the beginning when someone is more likely to have relapses. We know that with MS, the risk for relapse goes down with age and time. So why wait until someone has had several relapses and their risk for a new one is lower to start using the medications that work the best? So my approach in general is early highly effective therapy, and that's the rationale. When people are at highest risk for relapse, I want them on the best medicine to prevent relapses. Regardless of what we choose, we're treating to a target. So the target that you may have heard of is something called NEDA, or no evidence of disease activity. This means no relapses, no MRI lesions, no disability progression, but we're also looking at a lot of other measures now. We're looking at brain volume, we're looking at cognitive function, we're looking at lots of other measures to make sure that we're treating the MS all the way. In the category of highly effective therapies, this is how I rank things. So every MS specialist you talk to may have a slightly different categorization, but this is kind of how I think about things. We have natalizumab, we have B-cell therapies, and there are several things in that category. Natalizumab is given as an infusion every 28 days. The B-cell therapies are a little bit different. There are two that are given once every 6 months, and then there's one that is given by self-injection every 4 weeks. Alemtuzumab or Lemtrada is another highly effective therapy, and it has a completely different regimen. It's given once a year for 2 to 3 years, and then no treatment for several years for most people who take it. And then there are medications that I would put in the middle of the road category. And these, all the ones that I have listed here are pills. And again, you know, the next MS specialist that you talk to may not have the same classification, but this is generally how I think about things. There are medications called S1Ps for short. These are once-a-day pills, and now there are 4 approved medications in this category. The first one in the category was fingolimod or Gilenya, approved in 2010. But in the last few years, we've had 3 other medications that are more selective, and that means, we think, fewer side effects join that category of S1Ps. There are fumarates, and many fumarates in that category. There are some that I don't have listed here as far as the branded generics. These are twice-a-day medications, so it doesn't matter which form of the fumarate you take, it's twice a day, and the most common side effects associated with those would be upset stomach and flushing, but most people tolerate these pretty well. And then there's cladribine, which is really unique in this group. It's kind of like that Lemtrada that I talked about, and that you just do 1 course a year for 2 years, and that's it. No MS treatment for many years after that. And then there are medications that I say have modest efficacy. We know that they do something for MS, and you know, the ones at the bottom of the slide transformed multiple sclerosis care. Before we had these medications, you know, there was not really anything we could do to prevent people from having rapid disability. So these medicines do work. Just because I say they have modest efficacy, I'm not saying that they don't work at all, but I'm saying that they're not the strongest MS medicines. So there's teriflunomide, which is also known as Albagio, and it's generic now. It's a once-a-day pill. And then there are interferons, which are all shots. Some of these are given sub-Q underneath the skin. Some of them are IM or intramuscular. There's one that's given every 2 weeks, one that's once a week. There are a few that are 3 times a week. And then glatiramer acetate is another category. So there's a brand called Copaxone, and then there are many other generics, including branded generics in that category. But they all forms of glatiramer acetate work the same way. They're given as either daily shots just underneath the skin or 3 times a week shots. So my point in showing you all of these things is that you have lots of different options that can be given many, many different ways, and they have sort of different, you can think of them as having different strengths. So how do we choose among all these things? And it's really an individual decision. You know, when people ask me, well, Dr. Willis, what is your go-to medicine? What do you want to give to everybody who has MS? And I don't have an answer to that. There is not a go-to medicine. It is an individual decision. Sometimes, you know, if someone works in the healthcare field and they have high exposure to infectious diseases, we may go with something that doesn't suppress the immune system very much. So there are occupational things that we take into consideration. Lifestyle is important. You know, if you have a job and you can't take off 1 day a month to get infusions, a once-a-month infusion is probably not going to be the best strategy for you. You know, it's also helpful to think about what other medications someone takes. Some of these medicines have medication interactions, and they can't be mixed with the other things that someone may be taking. There's also a discussion about safety versus efficacy. So how safe is a medicine? What is your worry about side effects versus how well it works? So there are lots of things that we have to think about. One thing that I didn't put on this slide that we also have to think about is family planning. So, you know, someone who is wanting to get pregnant in the near future, they shouldn't take some of these medications. And so we have to have a discussion about, you know, what are your plans for the future? So people ask me, well, how fast do I need to decide? Do I have to give you an answer, Dr. Willis, today about which medicine I'm going to take? And my answer to that is no. I actually discourage people from deciding at the first visit or the first discussion about a new medication. It's important that you understand the side effects and the risk associated with the medicine and the choices that you have. So when thinking about how long you have, remember the effects of IV steroids are going to last for about 4 weeks, the immune effects. So you know that you have at least that window of time. And starting within the first year gives us the best outcomes. So I don't want people to drag their feet and take 2 years to make a decision. But if we can get to a decision within a few months, that's not going to change the overall outcome. So other methods that are being studied, some of you may have questions about stem cells. This is always a popular topic. The goal that most people have for stem cells is repair. And we've had several early safety trials to know that we can give certain types of stem cell aimed at repair. We can give them safely without side effects or harm to the body, but so far we don't have any data to show that they work to help with repair. It's not quite the same as giving stem cells in someone's knee or someone's neck, like you may have heard of from professional athletes. But they are really excellent for prevention. So we know that a certain type of stem cell therapy called hematopoietic stem cell therapy that basically uses stem cells to reboot the immune system, this works very well for people with relapsing MS. We don't have good data for progressive MS yet, but this is a very active area of research that you'll continue to hear more about for years to come. Symptomatic treatment is always important. So the medications that I've talked to you about don't make people feel better. You know, the goal with the medicines, and nowhere on those slides when I talked about treatment targets did I mention someone feeling better. We don't want our medicines to make someone feel worse, but we don't expect them to fix fatigue. We don't expect them to fix numbness and tingling or walking problems. And for that, we use medication strategies sometimes, but we also need sometimes to get other people involved. Sometimes we have to get rehab specialists, physical therapists, occupational therapists, speech therapists, physiatrists. We have to get them involved in helping manage things. Sometimes we need to get psychiatrists or psychologists involved, either in testing or in treatment. And then, you know, if the problem is the bladder, we may need to get urology involved. The point of this slide is it sometimes takes a village to manage the symptoms that people with MS experience. One specific symptom medicine that I wanted to touch on, because I get many questions about this, is called dalfampridine, also known as Ampyra. That was the brand name before it went generic, or the MS walking pill. This medication is not new. It's been around since 2010. It does require that people take 2 pills a day, and the goal is that it improves the walking speed by stabilizing the damaged nerves. About 1 in every 3 people get results with this. So in general, if someone takes it for a couple of months and they don't experience an improvement in their walking, we should go ahead and get rid of that medicine. It's not a forever and ever medicine if it doesn't work. The potential side effects would be increase in bladder infections and risk for seizures. So in people who already have problems with those, we don't talk about this medicine or start this medicine. And then I'll close with just some general recommendations. Medicine is not the only thing that is important in living well with MS. Eating a healthy diet is incredibly important, and there's no specific MS diet. There are lots of things out there that you can Google and they'll say they're an MS diet, but there's not anything that's proven. So eating a healthy, balanced diet like an American Heart Association diet or a Mediterranean diet is really important. Getting regular exercise is important. We used to tell people with MS, don't exercise. We were wrong. Regular exercise is important. Not smoking, reducing stress, and taking vitamin D are also important. This slide says take vitamin D 2,000 units a day, but it really does, the dose has to be adjusted on what your level is. So this is something that your care team should be checking regularly to make sure that you have enough vitamin D. What about other things? Acupuncture, no clinical trials, it's safe, it's not gonna hurt you. Bee sting therapy, again, no clinical trials, we don't know that it works, but it may cause allergic reactions that are severe. Other supplements, we don't have any evidence that any other supplement for the nervous system helps with multiple sclerosis. Vaccinations, absolutely, especially if you're on a treatment that suppresses the immune system. Vaccinations are safe, but you do have to be careful with live vaccines. The most common form of live vaccine that you might be exposed to around here in adulthood would be the nasal flu vaccine, so don't get that one, but a flu shot is totally fine. So how do you stay informed? There are lots of ways to do that. Hopefully we'll have more events like this to help keep you informed. But talk to your doctor or your care team. Ask lots of questions. I love it when people come in with questions and a list of questions. MS Views and News, National MS Society, and the Multiple Sclerosis Association of America also have lots of good resources on their websites.
Let's give the doctor a round of applause, everybody. Thank you very much. So who wants to start? Come on.
Yeah, Ricky's back
good.
there.
We got a person there. That's good. On my way there, though, I want to ask you, what can you tell everybody about biomarkers?
What can I tell everyone about biomarkers? This is a very exciting area of MS research. So I mentioned right now one of our ways to look for MS activity under the surface, so to speak, is with repeat MRIs. We would love to have a way to monitor the MS better than that and to look even deeper than looking for areas of scarring or new lesions on MRI. And biomarkers are how we're going to do that. So biomarkers will hopefully be helpful with diagnosis of MS, but also following MS activity over time. There are several very promising biomarkers. Neurofilament light is probably the one that you've heard the most about and is probably most ready for prime time. These are not commercially available biomarkers yet, and they're still being tested in studies to learn for sure if they can help differentiate MS from other conditions, and also to see the value of following the levels over time. So stay tuned. Neurofilament light is one of the closest, I think, to being available and part of your regular MS monitoring.
Before I take the question from this person, I'm going to ask you a few more questions about biomarkers that I think is informative for everybody here. You all meaning the doctors, the neurologists, you use MRI for a biomarker, yes?
Yes.
Can you tell people how you do that?
Yeah, so how we use MRI as a biomarker is we just like I showed you here in some of the slides, we're looking for areas of damage or areas of scarring. We're looking for active lesions, but we're also looking at the size, the volume of the brain as time goes on. In some places in big MS centers, your report from your MRI will include a volume measurement. So you'll know exactly how many spots you have. You'll know the overall volume of the spots to see if that's changing over time. But you also know the overall volume of the brain and different regions of the brain. So those are some of the biomarkers that we're using with regard to MRI.
Thank you. And what about the blood test that's now being spoken about?
So the blood test that's now being spoken about is actually not an FDA-approved blood test, and it has not been incorporated into the diagnostic criteria and compared to MS diagnosis by the diagnostic criteria. So I think it's promising, but it's not part of standard care.
What happens to a person who no longer has symptoms, and are they in a good place?
So what happens to a person who no longer has symptoms? Are they in a good place? In general, yes. However, I would say that sometimes the MS can be active and someone doesn't feel bad. I showed you one of the slides that showed you a whole bunch of arrows for MRI with stuff happening in the background before anyone had even their first attack or any inkling that they had multiple sclerosis. So generally someone who is not having new symptoms is in a good place, but it's still important to do regular MRI monitoring.
You don't get the mic.
I'm sorry. I keep on doing that, don't I? Dr. Willis, I've been to many of these meetings before for 10, 15 years, and I feel, Dr. Willis, that you are the best prepared and the best physician I've ever met. Let's give her a clap.
Thank you, Ricky.
Very good. Thank you. All right, that's all for now. Anybody have a question?
Hi. I was wondering, have there ever been any studies done in regards to viruses that might cause MS other than Epstein, specifically anything in regards to rats?
To rats?
Mm-hmm. Like viruses caused by rats?
Okay, so have there been any studies done looking at virus or infectious organisms besides Epstein-Barr virus in association with MS and specific to rats? I'm not aware of any specific to rats, but there have been some studies that looked at association with varicella zoster, the virus that causes chickenpox and shingles. There have been some studies that look at forms of chlamydia, not the STD form, but types of chlamydia that people are exposed to. There have been recently some discussion about looking at association of COVID and development of multiple sclerosis. There are a few other viruses, so what comes to mind would be herpes simplex, looking at the association of that, and a virus called HHV6. So there are other viruses, and probably more than that. I mean, that's a short list. Those are the things that come to my mind right away. But at the end of the day, I mean, the only one that has really stood out as a close association so far is Epstein-Barr virus.
So what made me think of that was the main ingredient in Avonex is a protein that's formed in the ovary of a Chinese lab rat. And I know the cause is almost always going to be called, the cure is almost always going to be found in the cause. And that's what made me think of that. If that is the main ingredient in Avonex, maybe that, in a sense, in some way, could be a cause. Maybe it came from a rat.
So that's an interesting thought, and gets at the production of some of our early medications, and one of the reasons that they weren't widely available. So some of you in this room may remember this, but the initial medications were only available through a lottery. So you couldn't get the medicines just because you had MS. You went into a lottery, and that was because the production took so long. It was made in Chinese hamster ovary cells, so that's true, and that production method took a long time. I don't know that that's related to the development of MS as much as it was the production of medications, of bioactive medications at that period of time, back in the 90s.
Okay, thank you. Anybody else have a question? Good, got one more hand going. And while I'm going there, one of the questions from online was, what can you tell us these days about how MS and COVID are causing issues for people?
What can I tell you about how MS and COVID are causing issues for people? Well, COVID has caused so many issues, whether someone has MS or not. One of the things in answering the last question I alluded to is there is some question about whether COVID can lead to development of other of autoimmune conditions, including multiple sclerosis. So, that's one of the things that I think is on the table. Many people who've experienced COVID have developed something called a long COVID syndrome, or that's what's commonly called in lay terms. And long COVID syndrome is associated with severe fatigue, brain fog, severe headaches, and these symptoms sound pretty familiar, right? So someone with MS who's already experiencing these symptoms, if they also have long COVID, it amplifies the symptoms they already have, sometimes to a disabling level. And then as far as the risk for COVID with some medications, this was an early question in the pandemic of, is it safe to continue these medicines, and should people be vaccinated before they're able to get the medicines? And what we learned from that is that most of our medicines don't significantly increase the risk of getting COVID, at least at a time where it was ubiquitous in the environment and everybody was getting it anyway. And they don't, for most people with MS, increase the risk of having a bad COVID infection, like the type of COVID infection that puts you on a respirator. So now what we've learned is that most people with MS can continue their normal MS medications, and that vaccination can be effective even if you're on most of these MS medicines.
Thank you. Question over here.
Where are we at currently with remyelination therapy?
Where are we at currently with remyelination therapy? We are not as far as I wish we were. So we are at the point where we are looking at strategies like stem cells for remyelination, where we're looking at different vitamin approaches that haven't panned out so far. We're studying other small molecules, mostly medications that are used for other purposes. For example, there was some hope that a medication used for seizures called phenytoin or Dilantin might help and stimulate remyelination if you give it early enough after an attack. And then there have been other, old medicines used for other purposes that have been studied for remyelination, and there are many large groups across the world that are looking specifically at the remyelination question. They're looking at it from a medication as well as an immune approach.
What can you tell us about MS being hereditary and how it might affect our offspring?
Yeah, what can I tell you about MS being hereditary and how it can affect your offspring? Like I mentioned at the beginning, there is some genetic component in the risk for multiple sclerosis, but it's not a hereditary disease in the sense that if you have it, your child will have it, or your cousin will have it, or your brother will have it. When we look at some of the old studies that were done looking at heredity and multiple sclerosis, it goes back to some old twin studies. So when identical twins with MS were followed, there was about a 50% risk of the identical twin having MS if the other twin had it. By the time you get to fraternal twins, it's about 25% or less. By the time you get to a child who has one parent with multiple sclerosis, that child's risk is about 1% to 2% higher than the rest of the population in the area.
Thank you very much. From online, from one of your local people who couldn't be here, the question is, can you talk about the new class of drugs known as BTKs or BTK inhibitors and their promise for future treatment?
Yes, I'll try to be brief. This is one of the things that I'm most excited about coming for 2024. So BTK stands for Bruton tyrosine kinase, and these BTK inhibitors affect the B cells in a different way than the other monoclonal antibodies that I talked about. This class of medications is also used to treat types of leukemia and has long been used to do that. But like some of the other medicines that I talked about that are used to treat other types of cancer, we use them at much lower doses to try to fine-tune the control of the immune system. The BTK inhibitors are particularly exciting to me because some of them cross the blood-brain barrier very well and have a chance to get to some of that smoldering inflammation, I think. I mean, this is still yet to be proven, but I think has a chance to get to some of that smoldering inflammation that may worsen progression with MS. So I talked a lot about medicines that are approved for treating relapsing remitting MS. My hope that is coming out of the BTK inhibitors is that they'll also have more of an impact on progressive MS than anything that we currently have. So stay tuned. This is, for me, it's a very exciting development that I'm watching very closely.
Thank you very much. Another question online. I don't quite get it, but I'll try to ask it. And if I say it wrong, I hope the person online corrects me and rewrites it. She writes, are women post-pregnancy always relapse after birth, even if I get onto MS drugs?
Okay, so the core of the question kind of gets at what is the risk for MS relapse during pregnancy and postpartum. So generally, women with MS have low risk for relapse during pregnancy, particularly during the third trimester. The changes that happen in the immune system to keep the body from rejecting the baby are favorable for women with MS because it kind of has a protective effect. Relapses can still happen during pregnancy, but they're much, much less common than they are prior to pregnancy. In the postpartum stage, those hormonal and those immune changes that are sort of protective during pregnancy reverse themselves. And so in the first 3 to 6 months after pregnancy, the risk for relapse is actually higher than it was prior to pregnancy. Some ways that we try to address this, all MS specialists have different strategies, and it really depends on the individual person. But the most effective thing is to restart MS medicine as soon as possible postpartum. So with some of our new medicines, that's very, very easy to do. And for the medications that are large molecules, like the infusions, someone can still get that medication and breastfeed because the medication is not passed along in the breast milk. So that does reduce the risk of having a relapse postpartum. We can't say that it's a fail-safe, but in general, restarting MS medicine as soon as possible after delivery is the best strategy for reducing that higher risk that happens after delivery.
Thank you. Next question is about MRI machines, 3T, 1.5, and what's next?
MRI machines. If I could have my way, everyone would get their MRI on a 3T or 3 Tesla magnet. So that's the field strength. It gives us much better quality images. and if everyone could tolerate it, having it on a closed MRI instead of an open MRI, particularly when we're looking at the spinal cord. So those things give us more data, a clearer picture of what's actually going on in the brain and the spinal cord. Now, that being said, we can still get pictures on a 1.5T that are helpful in following the MS and making decisions. In our local area, most of our scanners are 1.5 Tesla magnets. The open scanners are a little bit lower field than that. So I would say that the 1.5 Tesla imaging is adequate, but if I had my way, everyone would get 3T imaging. 7T imaging and 14T imaging is available in research settings. I know some of you are looking at me like, are you serious? The 7T magnetic field can be intense. So, if already at the 1.5 or the 3T you feel dizzy or, you feel like you're spinning a little bit, that effect is amplified at 7T, but it gives us beautiful pictures that are, almost the same as if we were actually looking at the brain. There are some newer techniques, some newer imaging techniques that are being used at other centers that can only be done on a 3T. I mean, we can see 3D images of the brain, which is pretty cool on a 3T MRI. We can also look at individual tracks through special sequences on a 3T. And that's why I say if I had my way and I could make sure that everyone gets imaging on a 3T, that's what I would choose.
When you speak about the 3D, are you speaking about the icometrics configuration with the AI technology?
It's not necessarily icometrics. There are several different platforms that are good.
Okay, thank you. Next, person wants to know about pain management. What can you talk about?
Well, that's a very broad question. What can I talk about for pain management? So a lot of the pain that is related to MS specifically is nerve pain, or what we call neuropathic pain. So this is tingling, this is burning, this is shocking sensations, and the best approach to treating that is to use medications that are specific to nerve pain. Some of the pain with MS doesn't directly come from the MS, but it comes from the effects of the MS on other parts of the body. For example, if someone's leg is weak and they're now swinging their leg out to move their leg forward, that puts wear and tear on the hip joint and the knee joint that it's not meant to take. And you can develop pain in those joints as a result of that wear and tear. So that's treated much differently than nerve pain. There can be pain from muscle spasms, and when that's the case, we use spasm medications. So, treating the pain with MS really depends on the underlying cause. And it can be really challenging when there are lots of different things going on. So if there's weakness, if there's spasms, if there's nerve pain, if there's already arthritis there, it can be really challenging to pinpoint what exactly is going to make the most difference in pain management.
What do you prescribe to your patients for what they can use alternatively for pain management? For alternative medications.
So, alternative medications don't really require a prescription. There are some things that people ask me about if it's safe to take over the counter or through a compounding pharmacy, and that's probably a more detailed discussion than we can get into. But one of the things that I feel is important as an alternative to all the medicines that I talked about, or as a supplement to all the medicines that I talked about, is non-medication approaches. Things like physical therapy or aquatherapy can be very helpful. And not just regular physical therapy, but physical therapists have a variety of techniques like dry needling, myofascial release, use of a TENS unit. So there are lots of non-medication ways to help with pain. And in general, I recommend that people do that either as opposed to pain medication or with it.
Thank you. Do you ever do CBD here?
I do not prescribe CBD here, and in the state of Mississippi, you have to have a special physician license to prescribe medical marijuana that was approved here. I don't have that license to prescribe, that special license to prescribe, because I am not educated on all the different forms that would be available at a dispensary. I talk in general when people ask me about, are there potential benefits of medical marijuana? Do I qualify? And what I say about that is there is some evidence for some types of MS symptoms that cannabinoid derivatives or derivatives of marijuana can be helpful with symptoms. So what I mean by that is in Europe, there is an oral spray that's approved. It's a 1-to-1 CBD to THC spray that actually does help with many of the symptoms associated with MS, with pain, with spasms, probably with sleep, maybe with bladder function. So that data is out there. There is some data for MS symptoms as opposed to symptoms of other neurologic conditions that CBD and THC derivatives may be helpful. What I discourage people from doing who do get their medical marijuana card and go to the dispensary is that I prefer that people don't smoke. They don't use a smoked form. Anytime you burn something, you're introducing bad chemicals, harmful chemicals into your body. So if people choose to use medical marijuana as an alternative to some of the pain medications that I've talked about, I prefer the gummy forms, or they come in drinks and in tinctures, and there are lots of other forms that are not smoked. So just stay away from the smoked form if that's your route of managing pain.
Thank you. Next group of questions concern optic issues, nystagmus, diplopia, etc.
All right, so what's the question in that?
Well, the question is, can you tell people about what they could do, or what causes the nystagmus, or what they should be looking at? Should they see a neuro-ophthalmologist?
Yeah, so there are many different causes of diplopia, which is double vision, and nystagmus. One of the main questions is when someone has double vision is how recently has it happened? If it's very recent onset of double vision and it's there when you cover one eye, it means that we need to do an MRI, and we may need to be treating a relapse. So that's the first thing, is I need to know what is the timeline? Is this something that has been there for months or years, or is this something relatively new? Because that has a lot to do with the workup. Sometimes if the double vision just started yesterday, we completely skip the neuro-ophthalmologist and go straight to the MRI scanner to look and see what's going on. Usually the nystagmus, the diplopia is due to a brainstem lesion, a new brainstem lesion. If it's been there for a long time, the neuro-ophthalmologist can be really helpful in strategies to help with the symptoms. So for diplopia, for double vision that stays there for a long time, one of the things that may help is just putting a prism in your glasses. That may be enough to help with the double vision. With nystagmus, that's a little bit harder to manage. There are medicines that we try, but there's not a really good strategy for reducing the nystagmus when it's been there for a long time.
Okay, thank you. What do you recommend to people to swim in, and how warm of water or not, and when they're doing aquatherapy?
Oh, that's a good question. And so when someone is doing aquatherapy, you do have to be careful and ask about the temperature of the pool. There's not an absolute temperature that's a cutoff that I would say, well, you definitely can't get into that pool. But if it is a heated pool, if it's something that's above 80 degrees or so, I would say that, you can go in there for a short time, but don't let your first session in the pool be a long physical therapy session. Keep it to 5 or 10 minutes, see what the impact of that temperature is on your body before you try to get in there for a 30 or 45 minute PT session and find out that you can't get out. So the concern is that the warmer temperature of the water, definitely a hot tub will do this. So hot tubs, if you have trouble with weakness, hot tubs are a no-no, and unless you're just going to be in there for a few minutes and jump right out. Hot tubs and warm pools can worsen weakness. They raise that body temperature and worsen the MS symptoms, just like we talked about. So being in there for 30 or 45 minutes may feel good, but you get out and your legs are loose and wobbly.
Thank you. Question?
Dr. Willis, I know that some people think an optometrist and an ophthalmologist are the same, and they'll go to an optometrist. Would you address optometrist versus an ophthalmologist?
Sure. Optometrists, the main reason to go see them is if you have healthy eyes and you just need an annual checkup and you need to make sure that your glasses and contact lens prescription is right. That's the role of an optometrist. Ophthalmologists have longer and they have specialty training with diseases of the eye. So they're better able to look for things like glaucoma, inflammation in the eye. They're in a better position to take a look at the back of the eye and look for swelling at the back of the eye that may tell us that there's a problem. So if what you're experiencing is something that you don't think that a new pair of glasses is going to help, then you really do need to see an ophthalmologist instead of an optometrist.
If your particular MS isn't caused by genetics, can it then be caused by genetics by anyone in your family after you?
So if your particular MS is not genetic, could other family members have a genetic cause to their MS?
Correct.
I would say, yeah, I mean, in theory it could, but the other thing that we have to consider among family members is that very often they have similar environmental exposures. So it may not necessarily be that if multiple family members are involved that there's really a strong genetic component. It may actually be looking at what those common exposures are.
When it comes to aqua therapy, is there any research in regards to like ice water and doing aqua therapy with ice water?
Oh, I don't know the answer to that question. If there's research in doing aquatherapy in ice water, I'm trying to envision how hard it would be to recruit people to do that.
Like polar swimming?
I don't know if there's been any research in looking at polar swimming or doing aquatherapy with colder than normal water. I don't know. Some of those studies are hard to do, hard to get people to volunteer for. So that's interesting. I'll have to look that up when I get home.
What are the effects of low testosterone and MS?
What are the effects of low testosterone in MS? The main effect of low testosterone in MS is that it increases the fatigue. So one of the most common symptoms of low T is having fatigue and sometimes brain fog to go with that. And so if you already have those symptoms related to MS, the low T can worsen that. There was a lot of concern, and it seems at this point to be mostly theoretical, but the answer is not completely clear yet. There were concerns that testosterone supplementation may increase the risk of relapses. In a few small studies, that wasn't borne out, but it still remains a concern that hasn't been completely answered by research yet.
Can I add to that? There was something done with low T therapy or testosterone therapy and healthier memory. So that has been brought up also. Okay, the next one, somebody's asking about bladder issues and they want to know what they can do to stop having the need to run so many times in the middle of the night.
Oh, bladder issues are extremely common. And people at first, I think the first few times they see me, they're like, why? You're a neurologist. Why do you want to know about my bladder? And it's because, bladder issues can have an impact on many, many symptoms with multiple sclerosis. If you're getting up to run to the bathroom 5 times a night, you're not getting good sleep, so it's going to worsen your fatigue. So there are some basic strategies that can help, but we have to sort out, is it overactive bladder or is it urinary retention, inability to empty the bladder? People with MS can have either or they can have both at the same time. So the first step is trying to sort out, which one seems to be driving things. There are different medications for overactive bladder than there are for urinary retention, but there are also different non-medication strategies. So for someone who has overactive bladder, they go very frequently during the day and they have a lot of urgency, one of the best strategies is scheduled voiding, scheduling time to go to the bathroom. A nurse that I used to work with, who was a bladder specialist nurse, would tell people all day long, if you sip, you're going to pee, pee, pee. And what she meant by that, and giving that advice, was when you have a bottle of water, don't take the top off and sip it and put it back on and keep doing that all day long. When you hydrate, go ahead and drink the full bottle of water, and then you should be able to urinate 45 minutes or an hour after that. And that gives you some control and some freedom from the bladder urgency for many people, and sort of the overactive bladder sensations. For some people, that's not enough. As far as getting up in the middle of the night, sometimes that happens because of urinary retention. And the strategies that we use for that may include just not having any liquid after a certain time at night, may include catheterization for some people when that urinary retention can't be fixed other ways. May include medication strategies. Things like tamsulosin or Flomax can be helpful with that. So really the answer to that question depends on the symptoms. Does it seem more like overactive bladder or urinary retention?
Yeah, and is there a certain time of night that you suggest that people shut down from having anything to drink?
It depends on how disruptive the urination at night is. If it's 1 to 2 times per night and people can get back to sleep, then I think that stopping hydration when you take your last dose of medication, so for most people that's around 8 o'clock or 9 o'clock at night, is sufficient. But if it's 6 to 8 times at night, then not having additional fluid after dinner other than what you use to take your medication is the best strategy.
Thank you. I was going to ask you a question, but I forgot what it is. But no, I remember. It's about memory. All right. So the question is, what can people do to help them retain as much as possible word games and et cetera?
Yeah. So there are no good medication approaches to helping with the memory issues with MS. And I want people to know, first of all, that if you feel like you're having memory issues and someone is saying, no, you're not really having them, you probably are having some memory issues related to MS. The first symptoms with memory and MS are usually very subtle. It can be difficulty multitasking. So things that you could easily do before now seem overwhelming, and it's hard to maintain your train of thought, for example. So in that case, the first strategy is to stop multitasking, is to do one thing at a time and focus on that. So if you would have in the past read a book, listened to music, and been talking to your spouse at the same time, don't do that anymore. Just do one of those things at a time. So that's the first strategy when the memory trouble with MS begins. Some other strategies that are helpful are making sure that you're getting regular physical activity. So we have good evidence that regular physical activity helps with memory, not just in MS, but also in preventing dementia or in patients who have dementia. So that physical activity is important. Getting regular sleep and making sure that your sleep is good quality is important. One of the common reasons that people have worsening trouble with their memory is that their sleep is disruptive. So managing the sleep is important. Also, really taking a close look at your stressors. So anytime you're stressed, you're anxious, you're worried, your brain doesn't function as well because you're asking your brain to multitask when it's not able to do that very well. Another way to think about it is when you're worrying or you're trying to do many different things, you have a lot of apps open. And we all know what happens to our cell phones. If you got a lot of apps open, it runs slow. The same thing happens to your brain if you're trying to divide your attention among a lot of different things. Keeping lists can also be helpful. Having reminders on your phone, alarms for things that are important, like taking medications and appointments. Making notes is important. So, if your memory issues kick in when you're going to your doctor's office and you show up and you can't remember those 5 things that you want to talk about, it's helpful to make notes and maybe even send those electronically in advance of your appointment. So there are lots of little simple strategies that can help. You don't necessarily have to do word games or other ways to exercise your brain. It is important that you continue socializing. So social interaction helps with memory. So people who are experiencing memory trouble very often are embarrassed and try to withdraw from their normal social interactions. And that actually makes the memory trouble worse. So trying to maintain your normal level of social interaction is important.
Thank you. Now, I hate to bring up this question while people are reading, but online, since we spoke about bladder, now they want to know about constipation. Okay, and so she was told that she needs to drink far less than she is, and this is causing the constipation. So what's next?
So it sounds like someone was told to drink less fluid, possibly because of bladder issues, and that has increased constipation. So that's a very common scenario. In general, managing constipation starts with making sure that you're well hydrated. It's hard for things to move along if you're not well hydrated. Making sure that you're getting enough fiber is important. So, when you're grabbing something for breakfast, or if you're skipping breakfast, you're missing out on an opportunity to get fiber in the day. And, Fiber is something that helps the stool form normally. Sorry to be graphic while you're eating. But fiber and hydration are steps 1 and 2. After that, stool softeners may be helpful. We try to avoid laxatives or other prescription medications. Sometimes a little bit of Miralax will be helpful. So this is something it's a powder that you mix in liquid. It's available over the counter at the drugstore, and you can kind of adjust it to how frequently you want to have bowel movements. Physical activity, getting up, walking around more, is also something that helps the bowels move better. The bladder works better as well if you're getting some physical activity. So those are some just basic strategies for managing constipation. There's, if it gets beyond those strategies, that's a more in-depth discussion that sometimes involves getting someone to a gastroenterologist for testing.
Thank you. So that's it, unless somebody has a question out here. Anybody have a question? Let's give the doctor a big round of applause.
Thank you. Thank you.
All right. Thank you very much for coming here tonight. I want to thank everybody for being here. This is a nice sized crowd. Our supporters of today's program were Bristol Myers Squibb, Genentech, Sandoz, and TG Therapeutics, and I greatly thank them for helping us and supporting us to do these programs. And that's all for tonight, so I'm going to say goodnight to everybody, except those in the room. You got to stick around for a while. But everybody online, thank you very much for being here.